Good evening and welcome to the Florida Academy of Family Physicians 7th installment of COVID-19 webinars developed to assist family physicians and their staff in dealing with the coronavirus crisis. My name is Jay Milson, FAAFP Executive Vice President, and I am once again broadcasting from one of several FAAFP satellite offices, my upstairs bonus room. I will be co-moderating tonight's webinar with FAAFP COVID-19 Task Force Chair, Dr. Chris Scuderi. Good evening, Dr. Scuderi. Our topic this evening, good. I was waiting for you. He's coming. He's there. Our topic this evening is one that certainly deserves special attention: addressing health disparities amidst the COVID-19 crisis. Our two presenters will provide examples of how existing health disparities have led to worse outcomes for vulnerable populations with COVID infections across the country, the impact this will have on future patient engagement in this demographic, and how lessons learned can improve health equity. Similar to all FAAFP webinars, participants will be in listen-only mode, but can type their questions that our panelists can see and will attempt to answer either during or at the end of the presentation. Our two presenters, as seen on the screen, Dr. Ross Jones, who is from the University of Florida Health and Family Medicine Center, and Dr. Bob Schwartz, Chair of the University of Miami Department of Family Medicine. So, I know what everyone is thinking but doesn't want to discuss. Will these gentlemen be able to get along, considering the bad blood between the Florida Gators and the Miami Hurricanes, particularly on the football field? Well, I was assured they would behave under one simple condition. I guarantee there will be college football this fall. So, being the service organization we are, I've made some calls to the NCAA, and I'm working on the issue as hard as possible. This is just yet one more benefit that the FAAFP membership can appreciate. What can we say other than you're welcome? So in all seriousness, we're going to get started, and we want to thank both of our presenters for being here this evening. Dr. Jones, do you want to kick things off and tackle the first question? Sorry, I couldn't resist. I had to say it. But how about we start with the first question for our panelists. How did the early message around COVID affect vulnerable populations, such as racial, ethnic minorities, and those in rural areas? Dr. Jones, why don't you kick us off?
Thank you for having me. I'm Ross Jones, Medical Director for Community Health at U of Health Jacksonville. So I think when we think about the early message around COVID, I think we all can agree there's a lot of confusion and mixed messaging. This affected vulnerable populations just as much as anyone else. As you know, social media has been a double-edged sword. There's a significant of people who get their information from social media, from Facebook to Twitter to Instagram. There's various myths going from screening to testing to prevention methods to actual treatments that actually had negative impacts, especially on these communities. If you go to the next slide, I can provide examples.
Okay.
As you can see here, we have two examples. On the right side, we have one of from, I believe that was Facebook, where it says that if you got a cold or in November, December, that you actually might have already had COVID infection. As we know, the first COVID infection in the US was not documented until January. So this can lead to many people who read this and believe that they don't need to be tested or be vigilant about the infection. And on the right, we have a Twitter from Brother Nature, who's a very popular Twitter and Instagram influencer. And then on the bottom right, you can see that he says that all you need to do to prevent COVID really is to drink enough water. And as we all know, you need to follow the different precautions such as social distancing, hand washing, wiping down countertops. So I think one of the things, the messaging here is we just need to make sure that as a position that we give out a clear, consistent message.
Okay, Dr. Schwartz, you want to follow up and kind of give your perspectives on the early messaging, particularly in your area down South Florida?
Sure. I thank you for inviting me, and I'm happy that we're talking about this. Obviously, the pandemic is a huge paradigm shift for everybody in the country, and certainly for us here in Florida. We have a very large minority population in Miami-Dade County and in Broward, and it certainly has impacted that population. As I'm sure most of you know, the numbers of minority, African American, and Hispanic patients who have been affected and have been put on ventilators and subsequently died is significant, much larger, unfortunately, than the Caucasian community. And of course, there are many issues. I'm sure that many of you realize that the minority populations tend to suffer from obesity, from heart disease, from diabetes, to some degree in a disproportionate way. And unfortunately, because of many complicated reasons, and we can certainly go into those through the rest of the seminar, wind up having more problems than average. We run a health center in Overtown, which is the historic African American community in Miami-Dade, and fortunately, our residency program is there, and we've been able to do a lot of community outreach, education programs of identifying people who have been affected by the virus and their contacts. And so there are certainly opportunities to improve the inequities that exist in the population, but people have to be certainly aware and motivated to do that.
Okay. Thank you. I'm going to let Dr. Scuderi introduce this one.
Excellent. Thank you, Dr. Schwartz and Dr. Jones, for your answers. Dr. Schwartz, how will healthcare systems handling of COVID-19 affect our patients' trust in healthcare systems as we move into the future?
That's certainly a good question. I've been on more Zoom meetings over the last 6 weeks than I can even count. I think the reality is that health systems are certainly motivated at this point to educate the population, and we're caught in a very difficult situation because, as was pointed out before, the media is not necessarily helping to educate the public. If anything, it seems to me that they're providing more fear than anything else. I think that medical systems, healthcare systems across the state and counties, federally qualified health centers have a huge charge to them to start providing really good education for communities. And of course, we all know about social distancing, wearing masks, washing hands. That's certainly been out in the media quite a bit. But I'm often surprised that a lot of times patients and communities are not necessarily paying attention. There are all sorts of other voices coming through the media which are downplaying the obvious risks. And our federal government at times doesn't seem to be necessarily helping to provide the best information. Our health system is working quite diligently in terms of developing systems for the hospital, for our own staff, for communication to our patients. As a matter of fact, tomorrow I was asked to be part of the video presentation to the community. One of the interesting things I think that we've seen is that many people are not coming into the emergency rooms. We run a 6-office urgent care program out of Jackson University, and the numbers have declined. And kind of all of us are scratching our heads trying to figure out why that is. And I think to some degree we're seeing a tremendous amount of fear and anxiety on the part of our population who are afraid of the healthcare system and afraid of getting sick in the emergency rooms and urgent care physicians' offices. So I think we have a lot of work ahead of us in terms of educating our community.
Thank you, Dr. Schwartz. And Dr. Jones, are you able to answer the same question?
Sure. So I think what this situation is really showing us is what is already the level of trust established in community with your healthcare system. I'm at the University of Florida health system in Jacksonville, which is a safety net hospital in Jacksonville, Florida. We're pretty much located in the urban core. So our mission for the last 150 years has been to take care of those most vulnerable. So throughout this whole epidemic, our patients have really leaned into us to figure out how do we handle this? What do we need to do to stay safe? I was actually surprised, even though many clinics around the country have reported decreased patient visits, our visits at the community clinics really have only had about half of what the other patients' drops in our clinic system have. And I think that's because they view us as their doctors, the people who are going to take care of them. So I think that this is just a good lesson for all healthcare systems that we really need to make sure that we're engaging our patients, even in times of outside of epidemics or any kind of crises, where we really need to make sure that we can establish that trust. A good framework, if you go to that next slide, is what American Central Hospitals created, which is these 7 dimensions of trust. So hospital systems kind of follow this pathway. It shows you some really good ways of how you can establish trust in your health systems. So some of them is pretty common sense, making sure it's a safe environment for your patients, making sure your people can trust. I think it's also one of the things that I want to highlight is community integration. You really have to partner with your community. You really have to know who are the influential leaders of the community, even those without titles.
Yeah, I'm going to jump in. I'm going to jump in, and I think that's a really important issue. I mean, certainly the faith-based organizations and community organizations, volunteer organizations are really critically important. But I think we have a responsibility to help prepare community health workers, especially in underserved communities. I think that that's an underutilized function, and I think that helping to educate people where they live is a critically important issue, and I think family doctors can play an important role in that.
I completely agree. We actually did some community testing in Jacksonville, and the way we really got our message out, the most successful way was actually working with people in the community. It was, the people who ran the local housing authorities, it was the managers there, it was local church leaders, it's just people who are just really advocates for their community who turned out the residents to get tested. And so far, over the last month, we tested about 1,700 people. We would have not gotten anywhere near that number without the help of our community members.
Those are all good points. I mean, it's kind of an interesting dynamic when you think about how we've tried to address the surge to emergency rooms for just basic care, primary care, and now in this dynamic, you've had this change completely. But how it brings it back is always the community, and I think that the 7 steps that you have there are really important for people to look at, and if they're having troubles in their own communities, that would be a great resource for them to be able to look at and utilize. So let's go on to the next question. What are you seeing in terms of your patients' concerns about COVID? I mean, is it specific to their ethnicity? Is it specific to their conditions, previous conditions, or give us some perspectives on that.
Sure. So for me, it's kind of like depending on what time of this epidemic that you asked, what were the patient's concerns? Early on, people were really concerned about loss of income, obviously. And then when the racial disparities came out, showing that African Americans had a much higher death rate and hospitalization rate compared to others, then they really started getting more scared about it. They were really fearful that they wouldn't be able to get tested. No one would treat them appropriately when they did get into the hospital system. So it was really just making sure that they understood how do they stay safe in this epidemic, and when do you really need to come into the hospital to seek treatment.
Yeah, that's really interesting, thinking about the socioeconomics of it is too. Dr. Schwartz, you seeing anything different down in Miami?
No, I think to some degree it's very much the same issue. I think patients are extremely frightened. I think that I've never had so many patients asking for anti-anxiety medications as I have in the last 6 weeks. People are definitely frightened. They're very afraid, and of course what you just mentioned about socioeconomic issues, people losing their jobs, not actually having enough food to eat. And of course, the county here in Miami-Dade, I think, has done actually a very good job of trying to get out and feed people. Even the city of Miami Fire Department and Miami Fire Rescue has put together a hotline so that elderly patients and elderly minority patients who are confined to homes, if they need to be tested, they actually, there's a hotline call-in number, and they will go out and test them in their home. So we've certainly tried to address a lot of the issues, but as I mentioned before, and as I think everybody is aware, you know, you turn the news on, and it really is, it does more to frighten people and make the situation, I think, worse than to some degree it actually is. I mean, the numbers of deaths that are certainly increasing, but when you see the larger numbers, they don't necessarily correlate to your own community. For example, as of yesterday, there were only, I think, 25 inpatient deaths during the entire time of the epidemic at the University Hospital. And yesterday, there were only 8 patients on ventilators. So if you compare that to what's going on in New York City, obviously that there is no comparison to that. And so I think we've been very fortunate, but not necessarily in the minds of our community.
Thank you, Dr. Schwartz, for pointing out about the anxiety. It's been one thing that I've noticed with telemedicine. One of the things that the patients have really appreciated is just somebody to just encourage them and let them know that's okay. And so I've been seeing very similar that it's just an amazing amount of anxiety in our patients, during this time. The next question is for Dr. Schwartz. We'll start with, how do we use technology to ensure that healthcare disparities are not exacerbated?
So that's a really good question. We were very early on, at least in family medicine at the University Medical Center, that we adopted telemedicine. And it's been extremely important because, of course, patients, we were locked down. Patients were not allowed to come into to our clinics. And being able to face-to-face with patients certainly made a huge difference for people, that they could see their physician. There was a friendly face. There was the opportunity to ask questions and talk, and to some degree counteract a lot of the misconceptions that people have still and were having about the infection rate. Again, not every one of our patients, and certainly there's a disparity in our racially ethnic population in terms of the ability to have computer access. And so a lot of what we did then was to turn to telephone calls, the old-fashioned telephone. And although it's not quite as good as telemedicine, certainly the ability to talk to people on the phone and help them understand what risks they were facing and what they could do to protect themselves certainly became evident. Our residents in our family practice program actually did a lot of door-to-door outreach in our community. So there are multiple ways of approaching this problem, but certainly I think telemedicine is here to stay, and I think it's a great opportunity to equalize the disparity between the socioeconomic and racial disparity issues.
And thank you for that answer. And it's been amazing to see telemedicine just explode. And I think it's going to be very difficult for our practices and our patients to go back. Dr. Jones, what's your experience been in Jacksonville with this and using technology?
Sure. So our experience was a little bit mixed at first. I think when we think about telemedicine, we also need to think about access issues. So for a lot of our patients, they're actually using flip phones. So it's really hard to do a virtual visit on a flip phone, as you can imagine. So we had to come away with some workarounds. Telephone calls were a great way. We also had involved staff members to actually call the patients earlier and have them set up virtual visits so that the patients would be talked through a virtual visit before they actually had one with the physician. This got them comfortable with the technology. And so that's kind of where we do it. And I think also what we need to do is start monitoring who's using the technology. So who's doing telemedicine visits? How can we make sure that we as a system are not perpetuating these disparities? And then also use technology to make sure we're monitoring all disparities across all fields. So the testing, early testing did not gather data on race or ethnicity. I think as you see in one of the earlier slides, you can see that almost half the states in the early testing sites didn't collect this information. So I think when we're going forward, I think we also need to think about an equity lens whenever we create any of these programs, from screening to diagnosis to treatment, or even going forward, to make sure that we're not perpetuating and making the situation worse for those that are already in vulnerable situations.
Okay, I'll take the next one then. How do you use the lessons learned that you've the things that we're talking about tonight to improve the health equity in your organization and your communities?
Sure. So if you go to the next slide.
Sure.
So for me, it's all about health equity. And so what health equity means to me is that we are finding appropriate solutions for that per individual patient's problem. So as you can see in the picture, if I gave everybody the same solution, it's not going to fit every person. And it's the same thing with the COVID. So we need to figure out, so the drive-through in Jacksonville, the drive-through testing was great for people who have cars, but we had a lot of people without cars and without access to reliable public transportation to get to those testing sites. So what do I do if I have somebody who's in the downtown who doesn't have a car, who's disabled, who can't make it to the bus stop? How do they get tested? So we have to think about, how do we do other ways to make sure that we're providing affordable services and high quality services to all those people who need it.
It's a great point. Dr. Schwartz?
Right. So, I agree. I think that, a lot of what has to happen is we have to identify and address the implicit bias that exists. There's no way around that. We also need to make sure that we have medical interpretation services. Certainly in Miami, we have a lot of patients who actually don't speak English. There's a significant Haitian population here, very mixed Hispanic population. And I have patients, fortunately, I'm fluent in Spanish, but I have patients who've been here for 25 years and still don't speak English. So I think that's clearly an important issue. We also have to reduce cultural barriers. I think it's very obvious. One of the things that we teach in our residency program are the important issues about breaking down barriers for people based on socioeconomic issues, on culture, on race. And I think that's really an important issue. And of course, learning about the economic disparities that exist across our community. Many of our medical students and residents don't necessarily have it or haven't necessarily experienced what our minority communities have, and that's certainly an important education opportunity for us in the healthcare industry.
I think also this highlights the importance of understanding unmet social needs and the social determinants of health. I think going forward, there's a lot of opportunities for us to make sure that we're screening our patients appropriately, and not only screening, but creating robust referral systems for those patients so that when we do find those unmet needs, that we have a way to fill it.
Yeah, I've been practicing medicine for a very long time, and I think one of the critical issues that we need are community health workers that are linked to our healthcare system, and I think family medicine is really the perfect place for those community health workers to kind of have a home with, so that we're not just involved in delivering healthcare, but really focusing on the entire biopsychosocial concept of individuals and community health.
Yeah, I completely agree. We're actually at UF Health Jackson. We'll be starting a program where we have a community health worker at one of our clinics who will help facilitate these referrals and help make sure that the patients can navigate their way through our healthcare system and with the other nonprofits that we partner with. So it'll be interesting to see how, if we do get that second wave, how it affects those patients.
Thank you both for your insights on that question. We have our first question from the audience tonight, so I'd like to present to either you, Dr. Jones, or Dr. Schwartz, and it is, one of the patient concerns is the threat of losing their jobs due to recurrent positive testing after recovering from COVID-19. How can we advocate for these patients?
Okay, I'll take the question. It's really a complicated issue. We are definitely struggling with the whole issue of how to get people back to work and which tests are appropriate. What we've seen is that the testing is not as accurate as we would like it to be, and some of the cultures are coming back negative, and the patient 3 or 4 days later will have a second culture and it'll be positive. The serology testing is not necessarily as reliable as we would like at this point. And unfortunately, there are many companies out there in the marketplace selling testing which have not proven to be accurate at all. So I think we have to really follow kind of CDC guidelines and use appropriate organizational structures to look at the testing. Many large healthcare systems do have protocols so that if somebody has tested positive and were admitted to the hospital, they have to have 24 hours in order to be discharged. They have to have a negative culture on 2 occasions with 24 hours between the 2 cultures, and then can go back. At the same time, as I mentioned before, there are some people who are asymptomatic carriers, and it's hard to know how to come up with a structural system to make sure that those people are not going back to work and infecting others who have not been infected.
And thank you, Dr. Schwartz, for that answer. It's been interesting. You know, amongst my patients, there's been certain employers who are very supportive and are really, paying for patients' leave, and there's been some that have been very challenging. So I think, there's disparities even amongst employers on this.
One of the issues I've encountered is that I've had dozens and dozens of patients asking me to order the serology testing, and right now, at this moment, Quest is only doing IgG testing, and LabCorp is doing IgM and IgG. So, if you have a symptomatic patient, it's important to know which tests you're going to order. And of course, if you're just ordering from Quest and getting IgG, that's really only telling you that the patient has not developed any antibodies, but you have no way of knowing at what point they are in either being healthy and completely asymptomatic, or whether they're in an early stage and they haven't had time to develop antibodies. And so there's got to be a lot of education that goes on with patients who are asking to be tested.
And I think we also have to realize that a lot of the people who are in vulnerable populations, especially those Black patients around the country who died from COVID infection, is that a lot of them were essential workers or frontline workers. And so we still have to use our voice as physicians to advocate for those people, to make sure that they have the proper protections at work, at their workplace. So that can be providing education, like Dr. Schwartz mentioned, or providing letters when they have chronic condition, letting the employers know that they're at higher risk. That's kind of some of the examples that we've been doing here at UF Health to try to advocate for our patients.
Well, that kind of sets us up perfectly for the next question. One of the person answered, that someone, she's come into the office, has no access to food because she's not yet received an unemployment check. How can patients recover from a disease if they don't have good nutrition? Poor nutrition makes them also more susceptible to infections. How can we advocate for those people who are hungry and desperate? I mean, this is not something that's necessarily new in terms of food deserts and other disadvantages that the uninsured or disadvantaged have, but certainly it's exacerbated by COVID. So thoughts about that?
Yeah, so like I said before, I think this is really showing. I think one of the best quotes I heard about this is, like, we're all in the same storm, but we're not all in the same boat. So we really have to realize as physicians that people are going through challenges and try to make sure that we have systems in place to answer those challenges. So one easy thing to do is most big communities have a food bank that have food and they have ways to distribute it. You might think about partnering with one of the food banks as a distribution center. You can also go to, I think it's here in Jacksonville, it's Feeding Northeast Florida. They actually have a website, and many of the food banks around the country do the same thing. They can tell you, you put in your zip code, and you can actually find somewhere where they're giving away food. So there's resources like that you can use. I think auntbertha.com is another one people use. The United Ways 211 line also is another great resource. So you just have to be aware, work with your social worker if you have one, to identify those resources, and probably the best thing is to create a little list that you can give to patients to let them know, or even better, have someone on your staff help connect them to it.
Here in Miami-Dade, I think we're very fortunate. We have a very large number of community organizations who've been doing a great job in terms of feeding the public. But I would think I would challenge our own organization, the Florida Academy, in the sense that these are statewide issues, whether it's in a rural area, whether it's in a large city, whether it's down in the Keys. There are always people that are going to be hungry, and certainly in this situation with so many people out of work, these issues are front and center. And I think we've got to do more within the context of our state government to make sure that there is enough resources throughout the state to make sure that people have access to food. I mean, I think that it is in this day and age, with being in the United States, with as rich a country that we live in, that it's just it's untenable to me, and I think to most of our colleagues, that people should go hungry during a pandemic like this just because they lost their job. And so I think that of course we need to lobby at the local level, but I think we also need to work very hard at a state level to make sure that our governor recognizes that a lot of resources need to be put into to the food supply system.
I completely agree. I think we also need to look at how do we use our voice as physicians on a state level and national level to eliminate food deserts. How do we advocate for our patients to make sure that they have access on healthy foods, even during times of non-crises? That's one thing here. In Jacksonville, there's tons of food deserts, and these patients are also in these neighborhoods also have a high proportion of diabetes, heart failure, obesity, and so they're still very vulnerable. But we still can't get them the foods they need to stay healthy.
Yeah, actually, the whole food issue and nutrition is one of my big areas of interest in it, and it's unfortunate that many of our minority communities eat very poorly, and so they, it's an issue that, of course, is important within the pandemic issue, but this is an ongoing problem. So if you walk into a supermarket and the first thing you grab is some chips and fried food, obviously bypassing fruit and vegetables, there's a huge opportunity for us to include nutrition in the way in which we counsel patients.
I'm going to have to push back on that statement a little bit, because you also have to make sure that you have to realize the situation that people are in. If they're stressed and they have limited dollars, people are very rational. They're going to do what's best for their family. So if they have limited budgets, and then I know that this pack of whatever processed food is going to last me for the month versus this, spinach or whatever is going to go out faster, they're going to take what's going to feed their family the longest. So what we have to do is make sure that those healthy foods are just as good of a choice for those patients. And so it's not as simple as saying they're making these bad choices. It's also making sure that they have availability, that they're available and affordable.
No, I agree. I agree with that, but I also think that some of it is habit, and people tend to follow long-standing habits, which are not necessarily the best for them.
Yeah, I would agree. I think that's something that, once again, it's those things that we struggled with before. We're struggling now. we'll continue to struggle with. It's human nature of what we deal with in terms of healthy behavior overall. And we're all susceptible to that. So family physicians do an excellent job of trying to counsel. But as I've always told people when we talk about this, whether it be legislators or regulatory bodies or otherwise, I mean, we all have the ability to make our own decisions. Our physicians, our members can advise the patients as much as possible, but they can't force them to be compliant with their meds or carry on solid nutrition and exercise and things like that. So it is a struggle, and it probably will continue to be. But I think family physicians, I think, as both of you have clearly stated, have that awesome ability of being able to have and be a great influencer in that and utilize resources to help the patients best as possible.
Yeah, and I think Dr. Schwartz earlier comments about community health workers, I think they are a really great tool to use to educate patients about making those healthier choices and how they can actually make it work within their particular life circumstances.
Yeah.
Agreed.
Well, if anyone else has any questions, you better get them in now. We are at the end of the questions that our presenters put out, and we don't have any other questions coming in from the group, and I can only stall so long. Dr. Jones or Dr. Schwartz, do you have anything else that you'd like to add before we wrap it up?
So what I would like to add is, oh, go ahead.
I have a quick question for Dr. Jones and Dr. Schwartz before they finish. So we're going from a tremendous economy to a very challenged economy. So over the next couple of months, many of our patients who have probably had insurance will be without insurance. How do we prepare our patients for this transition, and what resources do we recommend them to look at as they make this change if they've lost their job during this time?
So one of the things I've been trying to do is make sure all of my patients, just the bare minimum, make sure they all, especially ones with chronic diseases, have all the medications they need. So at least they have the prescriptions and they have the access. Another thing we've been doing is educating about other free clinics or safety net clinics, which may also become stressed as the economy downturns. To let them know about FQHCs, which are federally qualified health centers. At a lot of these different health centers, they can actually get care based on a sliding scale. So this might be more affordable than the traditional clinics they've been to while they were being insured, but it still provides some way to get access to care.
Yeah, I guess my comments are similar to that. We have a very robust FQHC healthcare environment in Miami-Dade. But I think it's at some point, family doctors who I think are at heart basically generous and civic-minded people. I mean, there's a way of helping people through the phone, telephone calls, and other group type meetings, going to a church session on a Sunday, volunteering to give lectures. I think there's a way of providing care that doesn't necessarily have to be a dollars and cents issue. So I think it behooves all of us to figure out ways in which we can provide medical education and healthcare without having it always be something that people have to pay for. I'm a big proponent of undoing our current healthcare system in terms of the way it's set up, because if you don't have insurance and you're not in some type of federally qualified program, you're not going to get adequate health care. And I think that it definitely ought to be one of the inalienable rights of being a citizen of this country is to have access to health care. So I'm giving myself away, but I feel very strongly that health care should be for everybody and not just for those who can afford it.
And thank you both for your insights. I think this is an upcoming issue that we're all going to face as family physicians. A lot of our patients go through challenging times. There was one more question that came up from the panel. It said the COVID-19 pandemic will exacerbate mental health disorders. Many patients need access to mental health care, but we do not have enough mental health care professionals. Appointments are hard to schedule, and often patients have to wait 2 to 3 months. What do you suggest to help these patients, such as group meetings or other options?
Yeah, I think we're certainly dealing with that now in a big way, and I think part of family medicine education has all been involved with mental health issues and behavior as part of the curriculum of residency training, and I think that I think a lot of family doctors who may not necessarily have been as comfortable dealing with mental health issues, they need to step up and do more of it, because the psychiatric community is I don't think is able to fill in that void, and I think that along with social workers and community outreach people, we definitely need to do more for those folks.
Yeah, I agree. I think we have to just get better training in it. And also, I think we need to use this expansion of telehealth to really make sure that we increase access to mental health services. So at U of Health, we have a pretty robust telemedicine program, which includes our licensed clinical social workers and psychologists. So we've been able to schedule patients who couldn't physically come into the clinic through this method. So we're able to a little bit increase access. But I think it's definitely going to be up to us as the family medicine docs to really step up and take care of these patients.
Well, go ahead.
I just, before we finish tonight, I'd like to put in a plug for the somewhat maligned CDC. If people want answers and very good information, the CDC has a whole section on the coronavirus disease of 2019. And it answers a lot of the issues that we brought up in the discussion tonight, and gives some very good solutions that people can put into place. It deals with the disparity issues. It deals with how to energize your community, how to focus on the virus itself and the symptoms, and it talks about testing. So if people have a lot of questions, it's certainly a good place to go for information.
So we'll take one final question. I guess I stirred up some additional interest, and it's a decent segue from what we talked about with mental health, because I think that what this question is asking about is domestic violence due to the stress associated with the coronavirus and the poor conflict management skills inherent to the population, so to speak. And how can we provide more efficient screening modalities for domestic violence?
Well, the only thing that I can say is that fortunately at the university and also at the Jackson Health System, in our electronic medical records, the questionnaires are built into our systems now. And so we have medical assistants who, as people are coming in for regular visits, are screened about domestic violence. And so when they ask patients to answer the questions, many patients will actually do, some patients won't, but then it's up to the family doctor to make that part of their history taking as they're approaching their patients. So I think it really the onus of kind of, and the burden of understanding which patients are at risk. You have to be aware that it does exist, and make sure that you're going to ask the appropriate questions. And then once you ask the questions and you get answers, you need to be prepared to act on that. And in this current situation, as we open up our clinics now to start seeing patients, try and get those patients in as quickly as possible.
Yeah, I agree. I'm pretty much right. Echoing what Dr. Schwartz said, I agree with pretty much all our screening is built into our intake process as well. But another thing we do is actually on the discharge paperwork, when we give the community resources, there's also a section just for domestic violence, so that if they don't feel safe to reach out to us in clinic, they still have the information to take home with them, so they can reach out to the appropriate organizations.
Yeah. Well, I think it's important always to provide those resources, whether it's like medical legal partnerships or law enforcement or anything else. It's certainly a benefit. Well, I guess that wraps it up. Any closing statements or comments that Drs. Jones, Dr. Schwartz, Dr. Scuderi, you want to make?
Well, I guess what I'd like to do is to wish us all good luck in this process. I think everybody realizes that healthcare in our country has changed dramatically, and we all have to be flexible in figuring out how we're going to go forward in terms of dealing with the difficulties that the pandemic has created at every level, whether it's at the federal government level, the state level, our community level, and within our own organizations. I've certainly, as I mentioned when we first started, never been to as many Zoom meetings as I have at this point, and it's become, to some degree, standard operating procedure. But it's also going to affect medical education at the student level. It's going to affect the way our family doctors out in the community are going to be asked to teach and educate our future physicians. So there are a lot of challenges that we're going to face, and I think for some people, they may very well become overwhelmed by it. And I think that we as an academy need to certainly pay attention to these issues and help our colleagues deal with not just the pandemic itself, but the fallout that will occur over the next couple of years.
Yeah, and I agree. And I also want to make sure that we realize that this is happening to all of us. So we still need to take care of ourselves and our staff to make sure that our well-being is looking after it as well, because there's going to be a lot of burnout, a lot of anxiety, a lot of stress. Even though our staff may have jobs, their family members may have lost their jobs. They may have lost someone to COVID infection. So we just have to be mindful of that and create systems or resources to support each other and our staff.
Well, very well said. Dr. Scuderi, anything?
I just wanted to thank Dr. Jones and Dr. Schwartz for just leading such great change in their communities and bringing awareness to this important topic tonight. This is amazing work both of you are doing throughout the state, and it really shows, and your passion for helping your communities really shows. And we just thank you so much for stepping up tonight and educating the rest of the family physicians in the state during this critical time. So I just want to say, Bill, thank you.
And thank you for bringing light to this important issue.
And thank you for inviting us.
Yeah, absolutely. And we really do appreciate your expertise. And I think it shines a light on many of our members that are out there doing this type of excellent work in their communities. And we ask that you continue it. If there's any way that we can help you, that's why we exist. Please don't hesitate to reach out to the FAAFP, and we'll either put you in contact with the speakers or resources that you may need that we haven't provided in the past. So this concludes the number 7 webinar of the COVID webinar series for the FAAFP. If you have any additional questions, submit them. As I said, we'll get them back to you as soon as possible. Don't forget all of the resource and information that we have available to us. We do post on our website at www.faafp.org. You can go to the resources page. We have everything on there from the webinars that you can re-listen to. We have the resource page. We have previous posts that talk about executive orders and all different types of information that help you practice during this. Next week's presentation will be on Thursday, May 14th. As you can see on the screen there, Return to Clinic, a pragmatic approach to resuming face-to-face visits. We're going to have Craig Lavoie out of Bayfront down in St. Petersburg, and Matt Rensberry, who's a DPC direct primary care physician out of Orlando. Both of them are FAAFP board members, and we hope that you'll join us to hear what they have to provide for us in terms of getting back to work, so to speak, from the practicing perspective. So we want to thank you once again for participating, and we just ask that you all be well, be safe, and good night.
Good night.